molar pregnancy. What is molar pregnancy?
Uncontrolled proliferation of
Trophoblast, yes. Abnormal proliferation of trophoblast is known as molar pregnancy. Complete and partial. There is two subcategory. One is trophoblastic disease and one is trophoblastic neoplasia. In the trophoblastic disease, mainly is H-mole. H-mole is of two type: complete and partial. Okay. And for GTN neoplasia, first is your persistent type. Persistent, it has two: invasive mole and placental site trophoblastic tumor. Trophoblastic tumor, placental site and invasive, comes under persistent. Then is your choriocarcinoma, the choriocarcinoma, and epithelioid trophoblastic tumor. Okay. These are the subcategories. Now coming on to your what happens, why it happens, or you can say risk factor. What are the risk factors for molar pregnancy? Does it occur in every patient? अच्छा, ये बताओ कहाँ पे ज़्यादा होता होगा, वेस्टर्न में कि एशियन पॉपुलेशन? हाँ, वेस्टर्न, एशियन, दोनों बोलते हैं. डेट बंद करो. Mainly it is more common in Asian population. Okay? In Western population, 1 is to 3,000 or 4,000 pregnancy, it can occur. In Asian population, it can occur up to 1 is to 400 or even 1 is to 150. Out of 150, one pregnancy can be molar pregnancy. So, but in Western countries, in 4,000 pregnancy, one will be molar pregnancy. Incidence is less, but incidence is more in Asian population. Or commonest it is in Philippines. Okay, most common incidences in, or it can commonly occur in Philippines population. Okay, so one is your ethnicity, Asian population. Second is your there is no proven factors. It can be genetic. Okay, some chromosomal involvement may be there. Nutrition, vitamin A deficiency can lead to. It is nothing is yet proven apart from Asian subpopulation, but vitamin A deficiency can lead to molar pregnancy. And one more thing is your strong familiar history. Familiar history is there, or if any previous past history is there of any previous molar pregnancy is there, the chance increases. Okay, and one more thing is blood group, AB blood group, A blood group. It is common in these blood groups, but it is not like it will occur only in these blood group. Last week, when cesarean section was done, she had a history of molar pregnancy previous. She was G4P0 plus 3, and the third pregnancy was molar pregnancy, and her blood group was V positive. That is not absolute, but it is more common in that blood group. Okay. One more thing is previous spontaneous abortion. If there is any history of previous spontaneous abortion, like in last case, it was 2 spontaneous abortion. So in third pregnancy, it was molar pregnancy. Okay. And age. In what age it can occur? Either very less, teenage, or more than 40 years. Less than 15 years and more than 40 years, or less than 18 years. Less than 18, more than 40. Okay. Extreme of age, it can occur. It is more common. So, what is the difference between complete mole and partial mole?
in partial mode, some fetal growth may be present
You can remember like this: trophoblastic proliferation is complete in complete mole, and partial proliferation is there in partial mole. Partial means कि trophoblast is not fully developed, or like in complete mole, so some fetal tissue can develop. There is some space for the fetal tissue, but in complete mole, abnormal proliferation of fibroblasts is so much that there is no space for the fetus to grow. What is the genetics? Genetics is very important in these two, complete and partial mole. What is the normal your chromosomal pattern? Huh? In complete mole, 40, 46x6. 46x6 is more common, that is 80%, and 46xy is less common. More common is 46x6. Why? And in partial mole, it is triploid. It is diploid. Diploid is there, and it is partial mole is triploid. Okay. Here 69x6y. Okay. 69x6x of 69xyy. Okay, this is more common. It is triploid over here. What happens in complete mole? There is empty ova. Okay, and once sperm is fertilized the empty ova. Okay, so here it is 23x and it is 0. Nothing is there. It fertilizes the empty ova and duplication of the sperm occurs and 46x's. That's why it is more common. One one sperm is fertilizing the empty ova. There is no genetic material in the ovum. Okay, ova is empty, and the sperm has genetic material as usual, haploid 23x. It fertilizes the empty ova. In the complete mole, we were studying. Complete mole is diploid, or partial mole is triploid. 49xxy. And in complete mole, 46x6 is more common. How it happens? One sperm is fertilizing the empty ova. In complete mole, just remember the ova is empty. There is no genetic material. There is no maternal genetic material. Only androgenesis is there, or paternal genetic material is there. Okay. So one pattern is this: one sperm is fertilizing the empty ova, and the sperm get duplicated, and 46x6 happens. One more pattern is if two sperms fertilizes the empty ova. There is no genetic material in the ovum, and two sperm are fertilizing. One is like 23x and one is 23y. What will happen? 46xy. Okay. But this is less common, like 5 to 10% only. Or mostly 80% is 46x6. Okay. So there is no maternal genetic material in complete mole. Only paternal genetic material. It is diploid. Okay. What happened in partial mole? There is genetic material of ovum, but the paternal genetic material is double. Okay. अच्छा, एक क्लास में बताऊंगी मैं, अभी वाला पढ़ लो पहले से. In partial mole, what is happening? It is triploid. Okay, so two sperms are fertilizing the ova. Like here it is 23x, 23x, and here it is 23y. Okay, so all the fuse and triploid happens. Okay, 46x6, 69x6y. Okay, so here genetic material of ova, maternal side genetic material is there, but majority of the genetic material comes from paternal side. Okay, here only paternal genetic material is there. Okay, difference between these two. Either ova is empty, here ova is genetic material is there. This is partial. Okay, so here because it is partial mole, so trophoblasts can develop not fully, but fetus can develop to some extent. Okay, because partial proliferation of trophoblasts is there. Just remember this: partial proliferation of trophoblasts is there. And in complete proliferation of trophoblasts is there. There is no space for the fetus. Okay, so there is two major difference. There is no fetus in complete mole. No fetus is absent. Where fetus is present. Either it can be just some part of fetus. It can be just IFD, or it can be just your IGR. Even IGR can be there. Even in twin pregnancy, partial mole can be there. Okay, complete mole can be there also. So fetus is absent in complete mole, and fetus some part or full fetus can be present in partial mole. Okay. सब पढ़ा दिया, चलो बताओ, तुम बताओ व्हाट इज मोलर प्रेगनेंसी, क्लास ऑलरेडी हैपेंड, सर इज टेकिंग द क्लास, बोलो what I told you, what is molar pregnancy? Trophoplastics, abnormal proliferation of the trophoblast. Okay, this is the molar pregnancy. This is of two types. First is gestational trophoblastic disease, and second is gestational trophoblastic neoplasia. Disease is of commonly known as H-mole. First is complete and second is partial. And second type is neoplasia. Neoplasia is different categories there, but what I am teaching you, it is given in shorts. Persistent type has two subtypes, invasive and placental. Persistent means कि some part is persisting inside the uterus. Molar pregnancy occurred previously, but some part is remaining. Okay, invasive mole and placental site trophoblastic tumor. These are the two subtypes. And choriocarcinoma, you must have read choriocarcinoma and epithelioid trophoblastic tumor. Okay, these are the subtypes. Achha, now risk factors more common in Asian population. Okay, like incidences 1:400 to 1:150. Okay, there is genetic. What are the etiology? Etiology not yet proven, but these are some risk factors. Okay, genetic of there is any family history there. Patient had past history of molar pregnancy. It is more common. Vitamin A deficiency and blood group, AB blood group, A blood group, and last is age. Extremes of age, it is more common. If teenage pregnancy is there, it is more common. Elderly patients more than 40 years, it is more common. Okay. Or less, I taught this genetic composition. This is partial. Okay. This is the main concept. Is this what happens? Okay. Ovum is empty, incomplete, and partial. Ova is genetic material is there. Okay. There are some salient features like when we will see the specimen, like you are having viva of molar pregnancy, specimen is shown to you. So what will common questions you will be asked? Risk factors already done. What is the chromosomal composition? You will take this is diploid, which is diploid, complete or partial? Complete. Partial is diploid. Okay. There are some more differences between the partial and the complete. Okay. First is abnormal proliferation of trophoblast is diffuse in complete, and here it is focal. Some area proliferation will be not overall. Okay. So diffuse proliferation is in trophoblast and partial or focal is in this partial mode. Okay. Then fetus, I already told you, fetus is present in partial mode, it is absent. And one more thing, period of gestation, what you will see on examination, fundal height, which will, in which case it will be more, complete or partial?
Complete will be more than period of gestation.
Huh?
Complete will be more than period of gestation.
Why? partial में तो ज़्यादा होना चाहिए, fetus भी साथ में that is the thing कि because it is 69:65, fetus can grow. Because fetus is already growing and trophoblast proliferation is only focal, in that case period of gestation of the fundal height is less than the period of gestation or just approximately equal to period of gestation. But in complete mole is like what we say, uncontrolled abnormal proliferation of trophoblast. There is uncontrolled proliferation. Trophoblast is growing here and there. So overall, uterus is occupied with vesicles only. So it is more than period of gestation in complete mode. Normally, patient will give history of when you will take the history, she will say, I have 2 months of amenorrhea or 3 months of amenorrhea. But when you will see the abdomen, it will be like 26 weeks, 6 weeks or 7 months pregnant mother. You will see this is like 28 weeks pregnancy, but she will give history only 3 months amenorrhea is there. Okay, so that will not match. That uterine size will be more than the period of gestation in complete mode. Okay, or because here trophoblastic proliferation is much more, it is more bad. It is not that dangerous. Partial is not that dangerous, but complete mole is dangerous. So here malignant potential is more than 20% or approximately 20%, and here it is less than 5% in partial mole. Okay? And in a USG, when you will see on a USG, what is the toxic finding of complete mole on ultrasound?
No sap will be seen, no heart to feel.
Some appearance is there, some term snowstorm
Snowstorm
appearance. Very good. This is very commonly asked question. Snowstorm appearance. Okay. Snowstorm appearance is, what is snowstorm appearance? Huh? It is the ultrasound appearance of the complete mole. Okay, in UAG you will see snowstorm, and in partial mole, what you will see? Initially, it will look like a missed abortion only, partial mole, and as the gestation age will advance, you may see some vesicles or the hypoechoic areas plus some fetal part. Okay, there is no characteristic usually finding of partial mole, but you have to diagnose. You will get to diagnose when the gestation age advances. And in complete mole, there is proper finding snowstorm appearance. I will show you later. Yeah. No fetus is formed in complete mole. In partial mole, in very rare cases, still now, very rare cases, fetus has developed and IUGR baby has been delivered, but very rare. Normally, fetus doesn't grow. Both of these. Complete mole, no fetal tissue is there. Okay, because no ovum is there. No ovum genetic material is there. Only sperm genetic material, but paternal genetic material is there. That's why no fetus is formed in complete mole. Okay. Or what you can say next is, what are the signs or symptoms? What will be the complaints of the patient? Symptoms.
abdominal pain,
First and foremost.
swelling,
First and foremost.
absence of
It is pregnancy, na?
amenorrhea,
Amenorrhea. First will be there will be history of amenorrhea, followed by what complaint patient will, or obviously patient is presenting you, she will be having some complaint at that point. At that point can be bleeding per vagina after a period of amenorrhea. Okay, a period of amenorrhea will be there. After a period of amenorrhea, patient will be complaining of bleeding per vagina and huh? No quickening. She will normally present you before that only. Normally, patient present at 14 to 16 or 20 weeks. Okay, before quickening only she presents. Swelling, no, because she's already done pregnancy test. Swelling, she's assuming this baby only. She will not complain of that. So there can be history of passage of vesicles. Okay, grape-like vesicle patient can say কি এখানে কিছু হ্যাঁ সাদা সাদা গোলাল ভাঙছে, এরকম কিছু বলবে বাংলাতে যে বলে বলবে ব্লাড ভাঙছে না, ব্লাডের সঙ্গে কিছু কিছু আসছে, সঙ্গে সাদা সাদা আসছে. They will not give you proper history of grape-like. You can ask the patient leading questions. Here is it some fetal tissue like or mass like or some cystic material like. You can ask the leading questions. Grape-like vesicles history can be there. Okay. Or and bleeding per vagina. They can be diffuse bleeding. Okay. And one is bleeding, and one you told pain abdomen can be there. And there can be weakness due to anemia, because anemia is very common in molar pregnancy because there is profuse bleeding, uncontrolled bleeding in molar pregnancy. Bleeding starts, many times it doesn't stop without any management. Okay, so patient can present with symptoms of anemia. Okay, and what are the signs you will see? Signs, pallor, weight like vesicles on per examination, uterus size will be more, and one more thing is there, just abdominal size is increased, but no redness is there. Achha, one more thing is, have you heard of any cyst associated with molar pregnancy? Any cyst? Any kind of cyst associated with molar pregnancy? There is theca lutein cyst, specific to it occurs in complete mole. It doesn't occur in partial mole. Theca lutein cyst. And it can be more than 6 centimeter, as large as 14 centimeter also. It can be very large cyst. Okay. Cyst can be, it can be found in ultrasound, and even on PV examination you can see theca lutein cyst. And pallor and pervaginal bleeding, PV, passage of vesicles, and period of uterine size will be more. And there are many other secret factors with molar pregnancy. First is, because what is the main factor? Why it is happening? All the things are why it is happening. Beta HCG level increases on when you will do blood examination investigation. First foremost thing is we do beta HCG level, serum beta HCG level. Okay, it is very increased in molar pregnancy. Normal pregnancy. Okay, but what the difference? It can be more than 1 lakh or more than 10 to the power 5 in complete mole. In partial mole, it is normally less than 1 lakh. Now, what is the usual level? There is corresponding level for every gestation age. There is corresponding level of beta HCG. Okay, it will be much more than that in molar pregnancy. Because why? Because beta HCG is separated from which part? Trophoblast. Okay, syncytial trophoblast. Okay, that's why it is syncytial trophoblast. Okay, that's why it is level is very much increased in molar pregnancy, because proliferation of trophoblast is there. Beta HCG as a result increases manyfold, much more than normal pregnancy. Okay, so for that you can't just get by doing UPT or doing pregnancy test. You have to do serum blood test. Okay, serum value of beta HCG. It is much more increasing complete mole. As a result, what happens? Hyperemesis gravidarum can be there. Patient can complain of severe uncontrolled vomiting. Hyperemesis gravidarum. Second is hyperthyroidism. Why hyperthyroidism occur? Because alpha unit of HCG is similar to TSH. So it stimulates the thyroid gland and thyroid hormone increases. So hyperthyroidism can be there. And what can be there? It also during complete more H mode, especially during evacuation, a chance of pulmonary embolism increases, as small vesicles can transport by your vessel or migrated to the lungs. Okay, pulmonary embolism chance increases. If a patient is presenting to you with breathlessness and saturation is falling, tachycardia is there, and patient had the history of molar pregnancy or is having molar pregnancy, you first will suspect pulmonary embolism. It is very common. Okay? Many times it occurs, especially during evacuation. You have to be very cautious. Acha, one more thing is your PIH. PIH, what is PIH? It is very common in this case. Why it happens? How PIH occurs? Because normally what happens to cytotrophoblast and syncytial trophoblast. Cytotrophoblast invades the maternal normal growth of placenta growth. Normally cytotrophoblast invade the maternal vessels and remodeling occurs of maternal vessel. Maternal vasculature remodeling occurs so that easy transport can be there between fetus or mother. Easy exchange can be there. Remodeling of the maternal vasculature occurs. But here, because trophoblast is abnormally growing, it doesn't cause the remodeling of the maternal vasculature. The abnormal vasculature or abnormal vasculature is there. Abnormal trophoblast growth is there. Normally, the remodeling that occurs at 12 to 16 weeks doesn't occur. That leads to PIH. PIH may causes also spiral arteries, whatever forms during the normal placentation, that is very less amount, or proper remodeling or spiral arterial formation is not there in PIH. Okay, normal PIH. But in here, that's the same etiology, but here no remodeling is there. No, not at all. So pH occurs less than 20 weeks. Normally pH occurs after 20 weeks. Whatever you will see hypertension in pregnancy, you will read in OBS. It occurs after 20 weeks. What we say? After 20 weeks, pressure rises. It is known as pH. And before 20 weeks, we will say chronic hypertension. But it here, less than before 20 weeks, hypertension can be there. All because of molar pregnancy. Okay. So these are the four important things just because of increased beta HCG and abnormal growth of trophoblast occurs. Okay. So what is the management? Investigation main is beta HCG. Okay. Acha, or other investigation are also there. Obviously, ultrasound, I told you, snowstorm appearance. MRI can be done. Usually we don't do unless and until there is any perforating mole is there. Many times patient presents with intraperitoneal hemorrhage. Okay, in that case, MRI is required if any perforating mole is suspected. Normally, we do USG, serum beta HCG. You can do blood investigation like thyroid profile, hyperthyroidism is TSH. You will do LFT, liver function test, and normal CBC. Your DIC is there or not, to rule out that, and coagulation profile because patient is heavily bleeding. So the basic investigation is this: ultrasound and serum beta HCG level. Or many times X-ray can be required by pulmonary embolism can be there. X-ray is required many times, but usually we don't do much. What is the management? Suction and evacuation. Suction and evacuation is the main management if patient is presenting an H mole. After suction evacuation, first and foremost thing, when patient comes to you, first you will send the serum beta HCG for blood investigation. Okay. As soon as the patient arrives, you have diagnosed this is molar pregnancy. You have done suction evacuation, you will send the blood for serum beta HCG. And second thing you will do after suction evacuation, you will send the sample of the vesicles or whatever the products of conception are there, you will send that for HPE because ultrasound, serum beta HCG level, these are just to aid the management, not the diagnosis. Diagnosis is histopathological examination. Only after histopathological examination confirmation, you will say it is molar pregnancy. It can be carcinoma, you don't know. It can be endometrial carcinoma also. That's why HP examination is very important to rule out any malignancy and to confirm the diagnosis of molar pregnancy. And other investigation just to aid the management. Okay. So suction evacuation, or here normally we don't do curettage. Curettage is contraindicated because perforation is very common in molar pregnancy. Okay. There is profuse bleeding. So what we give normally, we give oxytocin in these because uterine size is very much increased. We give oxytocin. Earlier we used to give misoprostol, but nowadays we don't give misoprostol because there is huge amount of bleeding after giving misoprostol. So nowadays we don't give misoprostol, just give oxytocin and do suction evacuation and methargin is given. Okay. During suction evacuation, pulmonary embolism can occur. So you have to be very cautious. You have to do very slowly. Okay. And many times because patient is having pallor and anemia is there, blood transfusion is required simultaneously after suction evacuation or before suction evacuation also blood transfusion is required. What is the other management apart from suction evacuation? Yes, we can do. If patient age is more than 40 years, family is completed, she has no plan to conceive further, you can do hysterectomy after, if patient is having H mole, confirm H mole. Okay. And any other management apart from suction evacuation? No, the medical management is there. Conservative. There is no conservative management. There is no conservative management. There is medical management also after suction evacuation, or if choriocarcinoma is medical management and conservative management, you don't do anything. You just wait and watch and decrease the symptoms. Okay. Medical management is you are decreasing the like patient is having bleeding, or patient is diagnosed as like you are doing heavy menstrual bleeding. Conservative management.
Treating the symptoms rather than treating the
Cause. Yes. This patient, you are giving symptomatic relief to the patient. You are not eliminating the cause. Okay. In medical management, you are trying to some decrease the cause. Like if here it is methotrexate. And most important thing is we give chemotherapy. It is known as chemotherapy over here. Chemotherapy, not exactly medical. It is chemotherapy. What we give in chemotherapy? Methotrexate. Take methotrexate, and there is imaco regimen. There is whole regimen. You will must have read in lecture. That is a lecture topic. But mainly is methotrexate is given IM along with folinic acid. Okay, there is whole regimen of methotrexate, and imaco regimen is also there. If choriocarcinoma is there, and there are different full guideline is there for imaco regimen. How you will give, how long you should give, and after management. And third is your hysterectomy. Okay, after normal management, what is the most important thing? More important than the management. What is the most important thing here in molar pregnancy? More important than the management. If you have done management but you didn't do that thing, it is waste. That is already done. Follow up. Follow up is very important. If you have done the suspension of the patient and you didn't follow the patient, it is a waste. Because follow up, because why follow up is important? Because there is high chance of conversion to carcinoma, choriocarcinoma. Okay? That's why you follow up. How you will follow up the patient? You will do HP in every setting. What you will do? So follow up, easiest thing what you can do. Investigation, I told you that. PTSD level is very good. PTSD level is done weekly. We have to follow till 6 months in normal HMO. And in different categories, different follow-up is there. Normally, we have to follow till 6 months. There should be no pregnancy till 6 months, okay, in normal HMO. And normally, till how many days, after how many days BTSCG falls? Not detectable in maternal blood. BTSCG कब तक रहता है? कोई प्रेगनेंसी है, अगर एक्समोल प्रेगनेंसी था, तो till how long you will detect BTSCG?
2 months after
2 months, approx 8 to 9 weeks we say. Up to 9 weeks BTSCG, it takes 9 weeks to fall. Okay, so normally it should not be detectable after 9 weeks. Okay, so but even if it falls after 9 weeks, we have to follow till 6 months, because abruptly many times there is plateau and then abruptly dies can be there. Okay, that's why follow-up is very important. There are many cases like patient came to us, the patient had history of suction evacuation like 2 years back. A patient was consulting a doctor for like 2-3 visits, and she didn't bother to visit the doctor. She changed the doctor. The new doctor didn't know her history. He didn't do the BTSCG. She didn't show the previous paper. She lost it, whatever was there, and he didn't. The serum BTSCG follow-up was not there. He again, when in second, third visit, the doctor came to know that she had a history of BTSCG, HMOL. He again gave the BTSCG level. It was raised. Patient again changed the doctor. New doctor, new treatment. Then again the same thing. Again suction evacuation was done without any indication. She was having bleeding PV, irregular bleeding PV, and BTSCG. There is actually a case. When I was in Bardhaman, there was a case. She changed doctors 2-3 times. She changed the doctor. Her suction evacuation, her D was done 2 or 3 times, and every time she was having irregular bleeding PV. And when it came to us, she was having serum BTSCG was more than 2 lakhs, and 2 years had already passed of first HMOL, history of HMOL, and on USG she was having full cost. And then evacuation regimen was started, and her age was not more than 40 years, but because of choriocarcinoma, her hysterectomy was done there, and she was responding very good after evacuation regimen. This is the only carcinoma after which patient can survive. Okay, if you have done evacuation regimen is properly given, it is the very you whatever say if diagnosed very well or follow up, you have done follow up very well, then patient can survive. This is the only carcinoma. Yeah, breast carcinoma is there also there, but here patient can prognosis is very good if diagnosis is earlier. That's why follow up is very important. Okay, the methotrexate response is very good, and if evaco is given, patient is given evaco regimen, then also response is very good. But metastasis is very less patients, or very incidence of metastasis is very less in cardiovascular. Okay, normally it's confined to uterus only. Okay, so management is already, main is follow up. Okay, हम लोग को एक photograph here. यहाँ पे we have pathology specimen, but that is not that good. That's why it's showing you this. This is the uterus, and these are the whole uterus is filled of vesicles. Okay, it must be around 16 to 20 weeks uterus. Okay, whole small vesicles is there. Okay. This is known as hydropic degeneration of the chorionic villi. Hydropic means the vesicles are filled with some fluid. Okay, transparent fluid. Or these are the vesicles. Okay. These kind of specimens are only given in examination. What one that is in pathology museum, that is not that good. No vesicles is properly visible. Acha, now coming on to your second topic is fibroid. What is fibroid? Definition. Soft tissue. It is benign or malignant? Benign or malignant? It is a benign soft tissue. Myometrium. Endometrium. Smooth muscle. Benign smooth muscle tumor. It is the most common tumor in the female. Okay. Benign tumor in female, solid tumor in female. So benign smooth muscle tumor. Okay. There are when you will see the microscopic view, there are smooth muscles and some fibrous tissue. So that's why it is known as also known as fibrosarcoma. Fibromyoma and neomyoma and fibroid. Okay, fibroid is a misnomer because mainly it is smooth muscle tumor, not fibrous. Mainly smooth muscle. Fibrous part is only very less. Acha, what are the different types of fibroid? And according to anatomical position, there is three types. Intramural, which is the most common, intramural, more than 75%. Then submucosal and subserosal, 15%. Most is intramural because it arises from the smooth muscle. Smooth muscle is present in the myometrium, what we told, myometrium, but that is smooth muscle tumor. Okay, that's only occur in myometrium. It can occur beside endometrium also, beside serosa also. Okay, and what is the there is one more classification of fibroid, Figo classification. Okay. Nowadays, you have to you have done palm coin, like you have studied the palm coin. No, you have to read this classification also. This is the new classification, Figo 2 and 18 classification. What is that? 1, 2, 3, 0 to 8. Okay. Basic I am telling you can't remember obviously whole. To 0, 1 and 2 is submucosal. Okay, ये पढ़ लो, सुन लो, इन क्लास किताब में नहीं मिलेगा. 0, 1, 2 is submucosal. Okay, इनसाइड से आउटसाइड स्टार्ट कर रहे हैं. इनसाइड से आउटसाइड तुम्हारा 0 से 7 जाएगा. ठीक है, 0, 1, 2 है सबम्यूकोसल. तुम्हारा 3, 4 है पूरा इंटरम्यूरल. ठीक है, 5, 6 और 7 है सबसेरोसल. ओके, अभी मोटा मोटा है, मैं बेसिकली बता रही हूँ क्या है एग्जैक्टली क्या है, बट ये मोटा मोटी याद रखना. 3, 4 मेनली याद रखो, इट इज टोटली इंटरम्यूरल. ओके, 0 is totally submucosal, 7 is totally subserosal. Okay, बाकी intermediate है. What is 0? 0 is pedunculated submucosal. Okay, 0. 1 is ज्यादातर अंदर रहेगा, ऑब्वियसली म्यूकोसा में ज्यादा रहेगा और इंटरम्यूरल कम रहेगा. दैट मीन्स मोर देन 50% इज, सॉरी लेस देन 50% इज इंटरम्यूरल. 1 नंबर. ठीक है, कि ज्यादा पार्ट अभी तो हम सब म्यूकोसल पार्ट में है, तो ये वाला ज्यादा ऑब्वियसली ज्यादा हमारा सब सेरोसल सब म्यूकोसल रहेगा 1 वाला. तो क्या होगा, लेस देन 50% इंटरम्यूरल हो गया. ठीक है, तो 1 इज लेस देन 50% इंटरम्यूरल. देन सेकंड इज सब म्यूकोसल कम हो गया, अंदर ज्यादा चला गया, तो मोर देन 50% इंटरम्यूरल हो गया. अब आ तुम्हारा 3 में टोटली इंटरम्यूरल है, बस जस्ट टचिंग द एंडोमेट्रियम. ओके, 4 is totally intramural, not touching endometrium or सब ये serosa. Okay. 3, 4 हो गया. अब 5 में same thing. 5 is more inside, तो क्या होगा, more than 50% intramural. 6 is to outer, less than 50% intramural. 7 is pedunculated subserosal. And what is 8? Not in the uterus. It can be cervical, it can be parasitic. Okay. Cervical, it is less than 1%. One hybrid classification is there if any myoma is very large enough. It is also in subserosal, also in intramural, and also submucosal. It will be termed at 2 to 5. Whatever region it is touching, we will call it as 2. 2 means ki it is in submucosal. 3, 4, 5. 5 is subserosal. So hybrid classification is also there. So you have to remember 0 to 7 main, 8 is extra apart from uterus, 0 is inside, 7 is outside, 3, 4 is intramural. Okay, mota moti. So what are the risk factors? There is no proper etiology for fibroid. What are the risk factors? Age. 35 to 45 it is more common. And smoking is protective. More estrogenic. The main etiology is estrogen. Estrogen is the main etiology. So whatever estrogen, whatever condition increases the estrogen, it will lead to fibroid. What are the conditions? Nulliparity, early menarche, late menopause. Okay, and estrogenic stage हो गया, और nulliparity, early menarche, and family history. Okay. Family, very strong family history. Okay. If family history, a mother or any sister family history is there, it can occur to for 1 degree, first degree relatives. Family history is very positive in this case, this factor. And what are the symptoms? Abnormal uterine bleeding. And what? One by one. Abnormal uterine bleeding. So normally we don't say abnormal uterine bleeding in this case. Normally what happens? Menorrhagia. Most common is menorrhagia. Intermenstrual bleeding occurs later. That is very rare. Normally menorrhagia is very common. Okay, menorrhagia. Why menorrhagia occurs in fibroid? It is more common in which type? Intramural, submucosal or subserosal? Which type? Submucosal, obviously, because endometrium is so, or the menorrhagia related to endometrium, because endometrium surface area increases. Okay, that's why menorrhagia can occur. And normally endometrial hyperplasia can occur at that area, and normal contractility of the uterus decreases due to fibroid. And the vasculature increases. So obviously to subtract the fibroid, many new vessels are formed. That's why menorrhagia occurs in the fibroid. Okay. And the second thing is your intramenstrual bleeding. It occurs in if any fibroid polyp is there, or if any erosion or abrasion is there on the tip of the fibroid or on the endometrium, then only intermenstrual bleeding occurs. Normally, menorrhagia only occurs. Okay. Second is your dysmenorrhea. Pain abdomen is later on. Dysmenorrhea. Why dysmenorrhea occurs? Most common dysmenorrhea is obviously proper contractility is not there of the uterus, and if any fibroid polyp is there, to exclude the fibroid polyp, uterus can contract and cause dysmenorrhea. Okay, but dysmenorrhea is less common in fibroid. Dysmenorrhea is more common in which condition? Endometriosis, adenomyosis. You will read adenomyosis later on. So, dysmenorrhea, if patient is primarily complaining of dysmenorrhea, it is probably not because of fibroid, because pain is less in fibroid. Mainly, complaint is menorrhagia. If old age patient or 40 perimenopausal patient comes to you with menorrhagia, so you can suspect that she might be having fibroid. Okay. If patient is complaining of only dysmenorrhea, so you have to suspect other things also, adenomyosis, endometriosis. Okay. The dysmenorrhea is there, but less. Okay. And
After menopause, there is no bleeding from the fibroid.
normally no, doesn't occur. Or क्या होगा? Infertility is very common in fibroid. Why infertility occurs? Interfere with the implantation. Proper implantation doesn't occur. And one more thing is there, it can obviously it hampers the proper motility of the uterus. So the sperm ascending, ovum transportation get hampers. It can block the tubes or the cornua. Many times fibroid can block the tuber cornua. The proper transportation of the sperm and ovum cannot take place, and even after implantation, proper growth of the embryo doesn't occur. It can lead to early miscarriage also in fibroid patient. Okay, so infertility, and later on your dull abdominal pain and pressure symptoms like increased frequency of micturition if it is anteriorly pressing on the bladder, and constipation if pressing on the rectum posteriorly. Okay, plump abdomen if it is very large, more than 20 weeks, lump abdomen patient can present, and many times if the fibroid is pressing on the ureter, hydronephrosis, any like pain abdomen can be there due to that also. तो ये हो गया तुम्हारा signs and symptoms. Okay, और क्या होता है? पैथोलॉजी में क्या हुआ? स्मूथ मसल में होता है. अच्छा, इसमें कुछ देयर सम what we say degenerations very common in fibroid. Okay, secondary changes. What are the secondary changes in fibroid? Have you read? फibroid का टॉपिक नहीं हुआ है ना अभी लेक्चर में. There are some secondary changes. इसमें एग्जाम में बहुत पूछते हैं, तुम्हारा यूजी लेवल में भी पूछते हैं. There are secondary changes in fibroid. Okay, इसमें क्या क्या होता है? Degenerations are very common. Degenerations and necrosis. फाइब्रॉइड है मतलब बहुत दिन से ग्रो कर रहे हैं, ठीक है, तो मिडिल में नेक्रोसिस स्टार्ट हो सकता है बिकॉज ऑफ डिवॉइड ऑफ वेस्कुलेचर, बिकॉज सेंटर इज डिवॉइड ऑफ वेस्कुलेचर. तो नेक्रोसिस कैन अकर, atrophy can occur when the patient reaches menopause or near menopause, so atrophy can there, and degeneration of many types. I will tell you later. Necrosis, atrophy, and hemorrhage can be there. Torsion can be there if there is subserosal fibroid pediculated, very heavy fibroid can cause torsion, get twisted on its own pedicle. So torsion can be there. Okay, and sarcomatous change. Okay, sarcomatous change can be there. It is very rare, less than 0.1%, but it can be there. A degeneration, very important. Most common degeneration is red degeneration, very important. It mostly occurs in pregnancy. कई बार ये leading patient पूछते हैं कि patient which degeneration is common in pregnancy? Red degeneration is common in pregnancy. Okay, this hyaline degeneration, pathology में पढ़ा होगा सर. Hyaline degeneration, red degeneration, और तुम्हारा cystic degeneration, calcific degeneration. These are different degenerations. Most important is the red degeneration because it can cause pain, fever in pregnancy. Mostly occurs in second trimester of the pregnancy. Okay, so red degeneration is the most common. Torsion, T for T for torsion, okay. R for red degeneration, S for sarcomatous pain, I for infective changes, N for necrosis. तो ये जस्ट छोटा सा न्यूमोनिक कुछ कुछ मेन चीज याद रखने के लिए, ठीक है. बाकी एट्रोफी और सब. T for torsion, okay. R for red degeneration से बाकी degenerations याद हो जाएंगे. S for sarcomatous change, I for infective changes, and N for necrosis. और necrosis से ही atrophy याद रख सकते हैं, ठीक है. ये just याद रखने के लिए, क्योंकि इतना याद रखना possible नहीं है. अच्छा, what is the management? Medical management and surgical management. And first is medical management. Okay, medical management क्या क्या देता है? And NSAIDs दे सकते हैं. And क्या देते हैं ओपीडी में नॉर्मली? Medical management of anorexia in case of fibroids. If fibroid is very less small in size. हाँ? OCP. First is progesterone. Okay. प्रोजेस्टेरोन ओनली पिल्स दे सकते हो, या जस्ट प्रोजेस्टेरोन दे सकते हो, तुम्हारा नॉर्जेस्टेरोन दे सकते हैं. ओसीपीज लो डोज ओसीपी दे सकते हैं. एंड वन मोर थिंग इज एलएनजी आईयूएस. एलएनजी आईयूएस नॉर्मली बहुत सारे गायनी में जितने तुम लोग का कोई क्वेश्चन पूछेंगे ना मेनोरेजिया का, मोस्टली का आंसर एलएनजी आईयूएस हो सकता है, ठीक है. व्हाट इज एलएनजी आईयूएस? इंट्रायूट्राइन सिस्टम और डिवाइस. ओके, एलएनजी आईयूएस मोस्टली जितने भी मेनोरेजिया हो रहा है तुम्हारा, एडिनोमाइसिस, एंडोमेट्रियोसिस, योर फाइब्रॉइड, in most of the cases LNGIs can be used as a primary treatment. If patient is refusing surgery or the fibroid is of very less size, small size, you can give LNGIs. Or patient is not reaching menopause, you can give LNGIs. And your progesterone only pills or just progesterones, nostoron, your different low dose OCPs can be given. And other medical management is, और क्या मेडिकल मैनेजमेंट है? कंसीव वो बता रही. अब और क्या मेडिकल मैनेजमेंट में आता है? GnRH एगोनिस्ट, ठीक है, एंड एंटागोनिस्ट. नॉर्मली वी यूज GnRH एगोनिस्ट. उसमें आता है लिप्रोलाइड, ठीक है. और तुम्हारा danazole, we can also use danazole. And GnRH agonist is very costly. And one more thing is, क्या पढ़ रहे? One more thing is उस बुक सुना है और meloxicillin, mifepristone पढ़ाया था plus. Mifepristone can be also be used in fibroid. It is very effective to reduce the size temporarily, not permanently. It can be used for 3 to 6 months. Okay, what is the dose here in fibroid? Abortion में कौन सा डोज यूज होता है? फाइब्रॉइड में कौन सा यूज होता है? 10 to 25. Very good. Normally we give 25 or 50. So 10 to 25 you can remember. 10 to 25 milligram can be given in fibroid patients. Continuous daily dose up to 3 to 6 months. Okay, mifepristone. And one more similar drug is unipistil. It is PERM, selective pristone receptor modulator. Unipistil. It can be used in a dose of 10 milligram, 20 milligram per day. Same daily dosing for 3 to 6 months. Why we don't give more than 6 months? Because there are many androgenic side effects. अच्छा, और this GnRH agonist like liprolide, it can be also given through 3 to 6 months only, or especially adenazole also 3 to 6 months. And rest medical management, your progesterone, your OCP can be given for 1 year, 2 year also. Okay? But these medical management can be given only for short period of time to decrease the size temporarily if you are planning for surgery, or if patient is not ready for surgery, or patient can't undergo surgery due to other medical conditions. Okay, she's not getting fitness, like patient is having severe heart disease, mitral wall prolapse is there, or injection fraction is very low, you can't operate the patient. In that cases you can give these medical management. Okay, now coming on to surgical management. ये मेडिकल मैनेजमेंट वाइवा में पूछेंगे लोग से, मेडिकल मैनेजमेंट तो तुमको आना ही है, ठीक है, आना ही चाहिए। अच्छा, सर्जिकल मैनेजमेंट क्या करते हैं? First thing, not hysterectomy. First is myomectomy. First you will say myomectomy, last is hysterectomy, because this is not cancer. This is not cancer. This is just benign tumor. You can just remove the myoma. A patient is not reaching menopause, or if this patient is young age, you can just remove the myoma. If patient is planning for pregnancy, patient is having infertility due to myoma, you will just do myomectomy, remove the myoma. It can be done abdominally, open, or it can be done laparoscopically. Okay, and myomectomy is the major option for infertility patient. Okay, you will not do hysterectomy in infertility patient. You will not do uterine artery embolization. Uterine artery embolization can also be done in for the uterine fibroid, but it is not done in patient who want to conceive. Okay, because the chance of conception many times decreases after uterine artery embolization. Okay, that's why it is not indicated in infertility patient. In infertility, one and only thing is myomectomy. If family is completed more than 40 years, or if medical management patient is not responding to medical management, you will do hysterectomy last option. The absolute treatment of fibroid or myoma is only hysterectomy. Okay, because if we remove the myoma, it can recur. Recurrence rate is very high.